Hi, welcome back to We See With Our Brains. When most people think of Parkinson's disease, they think about tremor, stiffness, and walking difficulties. But many people are surprised to discover that Parkinson's can also affect the way their eyes move, making reading difficult, causing double vision, and even making balance worse. Today I'd like to explain why that happens. Around 28,000 people per year are diagnosed with Parkinson's in the UK, and there are around 166,000 people currently living with the condition, and many of them will experience visual symptoms at some point during the condition. In my clinic, most people with Parkinson's tell me they've come to see me because readings become exhausting. They lose their place, struggle to find the beginning of lines, words become blurred or doubled, and after only a few minutes they simply give up. One lady recently told me she hadn't read a novel in over 6 months, and she loves reading and used to get through 2 or 3 books per week. She assumed, like many people, that she just needed stronger reading glasses. But although this can seem like an eye problem, it's actually the result of changes in the brain's control of eye movements. So let's start there. We all make little jerky eye movements, even when we try to keep our eyes perfectly still. This is completely normal. These eye movements are called saccades, which is a French word that literally means jerk or jolt. There are voluntary and involuntary saccades. Voluntary saccades are intentional eye shifts made to explore a scene, read, or look at something on command. Involuntary or reflexive saccades are automatic ballistic eye movements triggered instantly by a sudden flash, movement, or a noise in your side vision. Parkinson's disease mostly affects voluntary saccades, which are the ones that disrupt reading. This disruption also impairs the ability to turn. There's a mismatch between the eye movements and the speed of the patient's response, which increases instability and the risk of a fall. Then there are the smooth eye movements we make when we're tracking a moving object. In Parkinson's disease, often the eyes lag behind the object, or the eye's movement is interrupted by small corrective saccades, making tracking imprecise. One of my patients, a Saints fan, came to see me because he was finding it hard to follow the ball during a rugby match. One of the other main symptoms that my patients with Parkinson's disease mention is a feeling of visual motion, even when they're standing still, and it can make them feel a little uneasy or queasy. This is caused by something called square wave jerks. Square wave jerks are themselves a type of saccade, saccadic intrusions if you like, small involuntary eye movements that pull your eyes off a fixation point for a fraction of a second and then snap them back to whatever it was you were looking at. They're quite normal, we all have them, but in Parkinson's, these movements occur more often and they're also larger, leading to that disorientating feeling of visual motion. And all of these issues are caused by changes in the part of the brain that plan and control eye movements. One of the main areas involved is a group of structures buried deep in the centre of the brain called the basal ganglia. These structures act rather like a control centre, helping to start the right movements at the right time while preventing unwanted movements. Another important structure called the superior colliculus, which sits lower down in the brain in the upper part of the brain stem, acts like a rapid targeting system, helping the eyes jump quickly and accurately from one object to another. Then we have the frontal eye fields, which are found near the front of the brain, just behind the forehead. They're the part of the brain's planning and decision-making system and help you decide where to look next, particularly when you're reading, searching for something, or deliberately shifting your attention. In Parkinson's disease, these different parts of the brain don't communicate with each other as efficiently as they should. The basal ganglia send out signals that effectively apply too much brake, which prevents the superior colliculus from generating fast, accurate eye movements, while changes in the frontal eye fields make it harder to plan and initiate where the eye should move next. Imagine driving a car with one foot on the accelerator and one foot lightly resting on the brake. The engine's working perfectly well, but the car never responds as quickly as you'd expect. That's rather like what happens in Parkinson's disease. The eye muscles are perfectly capable of moving normally, but the brain's movement control circuits are applying too much brake, so the eyes become slower and less accurate. The other common issue that affects my Parkinson's patients is convergence insufficiency. If you remember from my previous video on this, convergence refers to the coordinated inward movement of both eyes so that they're both pointing at the same place at the same time, which is really important for tasks like reading. Convergence insufficiency upsets this coordination, which can lead to blurred or even double vision and eye strain. It affects at least a third of the people living with Parkinson's disease, a much greater proportion than in the general population. And this was the problem my book-loving lady at the start had. As with the eye movement problems we've just talked about, convergence insufficiency in Parkinson's disease doesn't happen because the eye muscles are weak. It's also caused by changes in the parts of the brain that control and coordinate eye movements. Remember the car with one foot on the brake? That's happening here as well. And in Parkinson's disease, there's a shortage of the chemical messenger called dopamine. Dopamine helps nerve cells communicate efficiently. When there isn't enough dopamine, the messages travelling between the basal ganglia and the brainstem become less accurate and less consistent. The posterior parietal cortex, found towards the upper back of the brain, which helps us judge where objects are in space and directs our visual attention to them, is also involved here. It should work seamlessly with the brainstem to keep both eyes pointing accurately inwards at the same target. In Parkinson's disease, though, the brain struggles to produce the steady signal that tells both eyes to remain turned inwards while looking at something close up. And as a result, one or both eyes may gradually drift outwards, making it difficult for the brain to combine the two images into one. And this can lead to blurred vision, double vision, and difficulty reading, especially for longer periods. And unlike in younger, healthy patients, where vision therapy is the gold standard for treating convergence insufficiency, in Parkinson's disease, this isn't the case because it's not a functional problem. It's being caused by underlying physical changes in the brain. Medication which mimics or raises dopamine levels can improve the convergence, but convergence insufficiency often remains to some degree, even with treatment. So to help these patients, I often use optical prisms in spectacles, and sometimes the patient has to have a couple of pairs, one for good days and one with more optical prism for days when the symptoms are a bit more problematic. And I know of one patient who simply wears an eye patch over one eye to stop his double vision when he's reading. The lady who hadn't read for 6 months found relief with a dedicated pair of reading spectacles containing optical prism and a good reading lamp. Never underestimate the power of good illumination. Usually these patients don't get on with bifocals or varifocals because the area of these lenses that's devoted to reading is relatively small. And as they already have problems controlling their eye movements and convergence, it just adds another layer of difficulty for them. In addition, even people without Parkinson's can find walking down steps and negotiating curbs more tricky in varifocals and bifocals, so they present more of a fall risk to people with Parkinson's. I certainly counsel my patients who live with Parkinson's disease against varifocals and bifocals. I find that communication is key. Often patients tell me they're relieved simply to know that there's an explanation. They assume their Parkinson's has suddenly got worse when in fact they're experiencing a recognised visual complication that we can often improve. Other problems I see in these patients are dry eyes. Most of us blink around 15 to 20 times every minute without even thinking about it. Parkinson's often reduces the blink rate dramatically, so tears evaporate more quickly and the eyes become dry, gritty and uncomfortable. It can also reduce tear production, which exacerbates the problem. We usually give lubricating eye drops and gels to relieve the symptoms, and occasionally refer to a corneal specialist for cyclosporin treatment. We also see an inability sometimes to lift the upper eyelid voluntarily, and or a persistent eyelid twitch, or both. The eyelid twitch is called blepharospasm, and again, the eyelid muscle is normal. It's the neural signals from the brain's control centres that are dysfunctional. In this instance, Botox injections can sometimes be used quite successfully. Visual hallucinations, which can be mild, sometimes happen, as though someone is standing nearby or something has moved past fleetingly in the periphery of the vision. Or sometimes the visual hallucinations can be quite alarming. They don't affect everyone with Parkinson's, but they're much more common than many people realise. Sometimes they're caused by the disease itself, sometimes by the medication used to treat it, and they should always be discussed with the patient's Parkinson's specialist. So now we're moving on to the treatment called deep brain stimulation, or DBS, which is used for some people with Parkinson's disease whose symptoms are no longer well controlled by medication alone. DBS treatment aims to improve symptoms such as tremor, stiffness and slow movement, and involves placing very thin electrodes which can deliver electrical stimulation into one of several movement control centres buried deep within the brain. These areas are located very close to the nerve pathways that control eye movements. You can think of the brain rather like a city with different neighbourhoods connected by busy roads, carrying information from one place to another. Although the surgeon aims for a very precise target, the electrical stimulation can sometimes spread to nearby roads, carrying signals to the eye movement system. Some of these nerve pathways carry messages from the frontal eye fields, just behind the forehead, which help us decide where to look next. Others connect with centres in the brain stem at the base of the brain, which send the final instructions to the eye muscles. If these nearby pathways are accidentally stimulated, people may temporarily notice changes in the way their eyes move. One or both eyes may drift to one side, the eyelids may blink or close involuntarily, or it may become difficult to open the eyelids. Some people also experience double vision. Fortunately, these side effects are not usually caused by damage to the eyes or to the brain. Instead, they're the result of the electrical stimulation spreading too far and affecting neighbouring nerve pathways. In many cases, they can be improved by adjusting the settings of the DBS device, rather like tuning a radio to maximise the benefits while reducing the unwanted side effects. As the channel name suggests, we see with our brains, so it makes sense that a disease like Parkinson's, which affects the brain, will almost certainly affect the vision. The important thing to remember is that visual symptoms are not simply something you or your loved one has to put up with. If reading has become difficult, if you're seeing double, if your eyes feel dry, or if you're experiencing visual hallucinations, tell your Parkinson's specialist, Parkinson's nurse, or your optometrist. Many of these problems can be improved, and recognising them early can make a real difference to the quality of life. Simple changes such as better lighting, taking regular breaks from reading, and using a dedicated pair of reading glasses with prism can sometimes make a remarkable difference. Whether you have Parkinson's disease yourself, or you have a loved one with the condition, or you're a newly qualified optometrist who wants to better understand and advise your patients, I hope you found this useful. If you did, please click like and subscribe to the channel. I'll see you next time. Bye for now.